Koutou and welcome. We'll open our hui today with karakia. Whakatakatiho ki te uru, whakatakatiho ki te tonga. Kia mā kina ki uta, kia mā taratara ki tai. Ihi ake ana te atakura, he tio, he huka, he hauhu, ti hei Māori ora. Kia ora koutou, nai mai, haere mai, and welcome to the second in our Crisis Responses webinar series. For this webinar, we'll be focusing on the findings of our recently published literature scan. It's my absolute pleasure to introduce Barbara Disley, who is a well-recognised leader in mental health and addiction and has been a strong advocate for many years to improve outcomes for those with mental health and addiction issues. We are privileged to have Barbara on the board of Te Hiringa Mahara and have her chairing our session today. Barbara's previous roles include Director of Mental Health Foundation, Executive Chair, Initial Mental Health Commission, Deputy Chief Executive, Ministry of Education, and Chief Executive of Emerge Aotearoa. She is currently a board member at Te Hiringa Mahara, the Mental Health and Wellbeing Commission. She's the chair of the Global Leadership Exchange, and she's a member of the Mental Health Assurance Group. Kia ora, Barbara. I'll hand over to you.
Ngā mihi nui, and thank you, Sonya. It's great to be here today for this kōrero. So our discussion today is going to focus on the literature scan that Te Hiringa Mahara recently published on the international and Aotearoa evidence around what makes crisis responses effective. And this literature scan is part of our monitoring work on crisis response and findings, and provides context for a forthcoming monitoring report that is currently being drafted and will be published in November. We're also having a forum in November. You'll hear a little more about that. So today we present an overview of the findings from the scan, highlighting some international and New Zealand examples referred to in that scan. So just a little bit of housekeeping. So there is a chat button, and that is visible at the bottom of the screen. So if you have a question, just press on that chat button and put your question in there. And then when we get to the chat session at the end, they'll all be there and we'll be able to move through the questions. So also, just to remind you, the event is run under our social media policy, and in short, we foster the exchange of ideas, but we do want people to be respectful and kind to one another, and of course that's what we would want for everybody in the world these days. Bit of a shame it's not. Okay, so just a little about our role and function at Te Hiringa Mahara. We are here as guardians, kaitiaki, along with so many others of you in the mental health and addiction space of our mental health and wellbeing area. And we're seeking to lead and support improvement in mental health and wellbeing outcomes. And this is so important for everybody in New Zealand, Aotearoa, to thrive. We're an independent Crown agency, and we're really committed to being grounded in Te Tiriti o Waitangi. Our key functions are to have system oversight, to keep an overview of what's happening across our sector, monitor, report, and also to advocate for change. Through our monitoring work, we shed light on things that are working, as well as things that may not be working, so that we can drive improvement. It's a very sad fact that it's a long time since 2001, when I was chairing the first Mental Health Commission, and we did a report on crisis services, open all hours it was called. And for me, it's a little disheartening to see that many of the things that we found back then are exactly the things that we are still looking at now to do better. One was having a clear overall direction for crisis services, as that was lacking. A pressing need to improve national level overview and assessment to ensure that crisis services and staff have the requisite skills, knowledge and support, and we had poor and variable response times, little or no access for Maori to culturally appropriate responses, issues of access and response and service coverage in rural areas, and inadequate responses to people who were in a state of intoxication or under the influence of drugs. So from, you know, when we then did the review in Waranga, and unfortunately going across and around the country saw little change. So Te Hiringa Mahara monitoring reports have found that crisis responses remain an area of high concern for people who with lived experience in their whānau, and also for many staff working across our sector. So I'll now introduce the speakers for today's session. The first is Sonya Russell, who will talk to you about Te Hiringa Mahara crisis response and provide an overview of the literature scan, including 2 international examples. And then we'll move to Ruth Borrett, who's joining us from Ember, and she will talk about New Zealand, one of New Zealand's examples referred to in the scan, a peer-led acute alternative service called Piri Pono. And then Matt Morris is joining us from New Zealand Police, and he'll share how the Wellington co-response team supports people in crisis. So welcome to you all. Thank you for being here. And I will now move over to Sonya. So welcome, Sonya, and I'll let you introduce yourself a little further.
Ora, Barbara. Kia ora koutou. No Croatia me ngā pui o ko tupuna. Ko Ngāti Pākau toko hapu. Ko Tahiki toko marae. Ko Sonya Russell toko ingoa. Ngā mihi nui kia koutou katoa. Kia ora everyone, I'm Sonya Russell and I'm a director here at Te Hiringa Mahara. Very pleased to be with you this morning. I will talk a little bit about our previous work in this area and why we focused on crisis responses for this year's monitoring report, before presenting some of the findings and examples from our literature scan. So as Barbara said, we continue to hear from lived experience communities about the challenges in accessing the right support at the right time when they're experiencing a crisis. Our Acute Options Insights paper, which was published last year, highlighted the need to increase the range of acute services available and also highlighted the key features of these services that resonate for people with lived experience. The literature scan is part of a package to understand crisis responses in Aotearoa. The Crisis Responses Project set out to independently monitor and provide insights on responses to people experiencing crisis, and also to define what a good crisis response system could look like for Aotearoa. It covers mental health and addiction services that respond to people experiencing a crisis, as well as emergency services like police and ambulance. And our main, as Barbara said, our main monitoring report will be published on the 4th of November. But this webinar is focused on the findings of our recently published literature scan. So we commissioned Synergia to undertake a literature scan for us, and it reviews international and Aotearoa evidence on crisis responses for the general population, Indigenous communities and youth, and it highlights shared principles, key differences, and what is working well. For the purposes of this literature, or for this work, it was really important that we were clear on what we mean by crisis responses. From a lived experience perspective, crises are deeply personal, so people experience them in different ways. But we worked really closely with our reference group to develop the following definition, which is crisis responses are forms of urgent support, assessment or intervention for people experiencing a crisis event that requires additional support to those provided in primary care or planned specialist care. So that is the working definition that we've used for this work. The literature scan draws on a range of models developed or evaluated in the past 10 years. And we wanted to understand what is happening overseas and what we could learn from other countries. But we also wanted to understand what's happening right here in Aotearoa. It draws on peer-reviewed journals, evaluation reports, grey literature, and sources reflecting lived experience, Indigenous knowledge, and mātauranga Māori, and drew on 119 different sources for this work. And those were the 3 questions we were seeking to answer. So yes, what did we find? Well, health systems around the world are working to improve crisis responses and face many of the same issues that we face here in Aotearoa. Experience shows that when crisis responses are embedded within cohesive system-wide frameworks, they produce better outcomes. These systems show how integration, cultural safety, peer leadership can reduce trauma, reduce the use of ED, and improve satisfaction and improve longer-term outcomes. The key features that the literature scan really highlighted of these models was 24 hours a day, 7 days a week crisis teams that can support people where they are, the importance of peer-led spaces, purpose-built therapeutic environments that are distinct from ED, digital phone lines and telepsychiatry options, and importantly, shared governance and national strategies that align across primary, secondary, and community care. So what is an effective crisis response model? Well, what the literature scan found that effective models value lived experience, they're non-coercive, and they're timely, holistic, and culturally grounded. They're also easily accessible and tailored to meet the needs. They uphold Indigenous rights and commitments and provide alternatives to emergency or justice-based interventions. The strengths so in Aotearoa there are some components that are working really well, and particularly our strengths lie in those relational, whānau-led and culturally grounded approaches. So that while there's a great collection of services here, not everyone has access to these, and often the most promising services lack robust evaluation. Positive impacts are often shared anecdotally, and there are a few long-term outcome studies. Kaupapa Māori, peer-led models and youth services are delivered locally, and there's evidence that these increase trust, safety and engagement, but again, they're not always readily available, and there's a little focus on substance use crises. I really want to acknowledge the many examples of great services that are being delivered right across Aotearoa, and many are referred to in the literature scan, but there's too many for us to cover them all here, so we've picked out a few. So the other question that we were really keen to understand is what works for Indigenous populations, and what the literature scan found is that when whānau and community-led approaches are embedded along with principles of Indigenous leadership and self-determination, then experience of services and outcomes are improved. When cultural practices are integrated into the approach and blended with Western approaches, they result in strengthened engagement and outcomes. And Mahi Atua is a really good example of how that's been done here in Aotearoa. We also wanted to understand what works for young people. And what we found is that services for young people really need to be accessible, non-clinical, and integrated into environments that reflect the preferences and needs of young people. Early intervention is important, and there's a real move away from hospital-based services to much more community-led and home-based. And in the literature scan, an example of this from Germany is an inpatient equivalent home treatment team who goes into young people's home to support them, but also ensure that continuity in school and family life. And they've been finding some really good results in terms of that approach. In Aotearoa, we do have some really good examples of this as well, and the child and adolescent acute response teams are another really good example. All right, so I wanted to talk through a couple of international examples that are referred to in the literature scan, and then of course we've got a couple of New Zealand-based examples as well that we're going to talk through. So first of all, the crisis resolution service, which is based in Ireland. And this service is a rights-based, equity-led, culturally grounded and relational model that embeds peer support and lived experience. The model aims to provide person-centred, community-based alternatives to hospital admission and focuses on the early intervention, aiming to address crises promptly within the community. And it has these two interconnected parts: crisis resolution teams, which are multidisciplinary teams offering rapid assessment and intensive short-term interventions in people's homes or community settings, thereby reducing the need for inpatient care. They're staffed by multidisciplinary professionals, including psychiatrists, psychologists, mental health nurses, social workers, and occupational therapists. Another key part of this model is what's called solace cafes, or what we call here is crisis cafes. They're non-clinical, welcoming spaces operating during evenings and weekends, and they provide immediate support and de-escalation for those in distress. They're staffed by a mix of peer support workers and mental health professionals, fostering a supportive and empathetic environment. CRS, or Crisis Resolution Service, is accessible for adults over 18 and who are experiencing a mental health crisis that does not necessitate an ED admission. And so they're open referrals through to those solace cafes, but for the team, it's referral through GPs, community mental health teams, and ED. So the other model that's referred to in the literature scan, which is a model that's possibly quite familiar to many of you, is the Trieste model, which is another approach that's covered in the literature scan. And this approach was developed in the city of Trieste in Italy in the 1970s, and it's widely recognised as an inspirational approach that radically transformed traditional mental health and addiction services. It was built on the vision of a mental health system which provides care and services where, when, and how people want them, and the importance of human dignity and freedom. And it promotes an open door, no restraint policy, so people can self-refer or walk into a community mental health centre without an appointment. Referrals can come from primary care, ED, or social services, and it's 24/7 multidisciplinary community mental health centres. So they provide walk-in support, mobile crisis teams, home-based interventions, supported housing, social cooperatives, and employment programs, and work very closely with social services, families, and the broader community. It has achieved very impressive results in terms of avoiding compulsion and seclusion is actually never used, and the compulsory treatment is rare compared to the rates we have here in Aotearoa. So that's just a couple of examples, and it's my pleasure to now hand over to Ruth, who will talk through one of the examples closer to home. Kia ora, Ruth.
Kia ora, Sonya. Kia ora koutou, everybody. So thank you for the introduction earlier, Barbara. I'm Ruth, and I'm privileged to be the Chief Operating Officer at Ember, Korowai Takitini. I'm particularly excited to talk to you this morning about Piri Pono. It's a service that, of all of Ember services, is very close to my heart. I live in the Rodney district where the service is delivered from. And I'm really happy listening to the feedback from the literature scan around having those acute alternatives local to the communities that they're serving and being more home-like. So I've got some very pretty pictures throughout my few slides just to show the environment in which Piri Pono delivers what is a peer-led acute alternative service. So we are in a semi-rural location, and these are recent pictures, or actually from the summer, I have to say. This is not today, it's raining very heavily here today. But this is the driveway and the environment which we intentionally have made as the antithesis of a hospital environment, if it's fair to say. And if I can move on a slide, we started this dream of Piri Pono probably about 15 years ago now. and there was a quite comprehensive co-design process that was undertaken for those accessing services, secondary services within the Rodney district and what I call the northern part of the North Shore, for those who understand the Auckland geography. And we had feedback that the community wanted a service that enabled the tangata Hauora to reduce their stress levels and maintain their space within the community that they know and love. That the service should provide a setting that is welcoming, safe, comfortable, supportive, reduces the need for hospitalization, but actively supports people within their community. And importantly, although not listed here, the whānau found that traveling reasonably long distances to visit their loved ones who may otherwise have been admitted to the inpatient unit at North Shore Hospital, that was quite confronting for them. It was difficult and challenging, and they wanted an environment that was more whānau friendly. So that's how the dream for Piri Pono came about. The service opened in September 2013, and the immediacy of that opening was the uptake straight away of people coming to stay at Piri Pono, and people can stay for a maximum of 10 nights, and they do have to choose to come, and that is a significant difference. People are in acute distress for Piri Pono, and access is 24/7, so 7 days a week, 24 hours a day. People can access Piri Pono, but they do come to the service via the crisis team or the Rodney Adult Mental Health team. So the staffing is purely peer-led and staff. That includes our nurses. Our nurses are lived experience. And I'm also very proud of the fact that the nurses working at Piri Pono, 2 of the 3 of them have come via Piri Pono as guests at some point. And if I use the term guest, that's how we identify with the people that come and stay with us. The clinical partnership component is really important. In order to have a safe and nurturing environment for people, which is accessible 24/7, you need to have a strong relationship with your local crisis team and clinical team. And we are really proud of that relationship with the Rodney Adult Mental Health Services. And those team members from there visit the service every day. And they come, and we do some medication changes there. We do a lot of work with people who would otherwise be in the emergency department or inpatient unit. And we can take the risk, if you like, and I'll talk about that a little bit in a moment, for managing those processes because of the links with the clinical team who do come every day to visit the Hauora that are staying with us and to assess and monitor how things are going for them as well. So really close clinical partnerships important. Some more very pretty pictures. So this really is not a hospital-like environment at all. People have their own bedrooms, and they get, if there's more than one bedroom vacant, they get to choose it. They're met on arrival by a peer support worker, and the warm, inviting spaces, the very home-like environment is indicative here of a very different place to stay. The only, I suppose, exclusion criteria, if that's the word we don't like to use, is if someone is physically unable to be in an environment where their safety will be impossible to maintain. We do have people that we have one-on-one support with at Piri Pono, but if there's going to be a significant risk to others because it is a shared environment, we do have to have people go to the inpatient unit or the emergency department, but we often will then, within a period of 24 hours or so, have them come back to Piri Pono if that's their choice. So last year, and this is to the year ending 30th of June, we had 238 admissions, which was 201 unique guests. Some people came through more than once. The average length of stay is 6.8 days, so significantly less than the 10-day maximum. And in that period, people feel settled. And as shown by the Kessler 10 scores that we use to determine or to help to see if we've managed to reduce people's psychological distress by a stay at Piri Pono. 85% of guests showed a significant decrease actually in their psychological distress, but that is self-administered and self-rated in terms of how people are feeling at the time that they move on from us. And occupancy at 89% was and is phenomenal. We do try to, because of the turnover, if you like, we try to keep a spare room so that people can always have access when they need it. So we consider 85% the new 100% normally when we're talking to this, but very, very high rates of occupancy. And I think that demonstrates a high trust from our clinical partners as well. And this is a quote from a guest who stayed with us, and it's a reasonably early quote, and I've used it because Piri Pono is one of only a handful of acute alternatives in New Zealand that genuinely take people into the service 24/7 in acute crisis, and the statement right at the end of this is we need more of them, and that really hasn't happened. So I think this is a plea to come through this work that's undertaken now to say evidence shows that these services work, and that if we were saying a decade ago we need more, that hasn't eventuated, and so we need to look at that. And I'm looking forward to answering any of your questions later on. I think I'm now handing over to Matt. Over to you, Matt.
Kia ora. Thank you, Ruth. Kia ora koutou. I'm Inspector Matthew Morris, obviously from the police, if you've got your screens on. I am the Health Partnerships Manager working at Police National Headquarters. But in my previous life, I worked at Wellington District, and I was the project lead on setting up the Wellington co-response team, which is what I'm going to talk about for the next few minutes. I've got some slides which we'll work through, and it's mostly kind of data focused. I'm not going to go through all the data. I'm going to be talking around them, and you can read the data on the screen as we go. But the little quote that I put on there, courtesy of a staff member who worked on the CRT at the time, is what I think is a core purpose of the co-response teams, and I'll describe what exactly that is in a second. That we're working in an emergency space here. There isn't time for appointments, there isn't time for referral pathways and all that type of stuff. It's an active, very busy space where decisions need to be made very, very quickly, often. And if you can get the support to people in their emergency as fast as possible, as is described in that quote there, you can stop the train from leaving the station, because once it leaves, it's a lot worse for everyone involved. So if we can get people to people as soon as possible, that's a win for everyone. And that's what the co-response teams should be doing. I'll talk a bit more about that in a second. Next slide, thanks. So I'm going to be focusing here on the Otago University evaluation of Wellington CRT. And that was essentially carried out at the launch of the co-response team in 2020, right at the beginning of COVID. Literally, we're having our first meetings, and everyone was talking about COVID. What the hell are we going to do? Great start point, but that's the way it was. What is a co-response team? The Wellington one, when we set it up, involved and still involves police officers, a paramedic from Wellington Free Ambulance, and mental health services staff from what was MHAIDS, and apologies, I haven't worked with the Wellington for a while, so I'm not quite sure of the latest terminology, but it was the 3 DHBs there, had some DAOs working on the team. They respond to 111 calls, they speak and assist other police staff and ambulance staff, they intervene in the 111 process where possible to provide a better care rather than just a standard police response. The data that you see on the screen here is from the Otago University evaluation that was carried out. Now, there are other models around the world in regards to these co-response models. The one that we set up was loosely based on an earlier UK model. I will say this about the evaluation that was carried out, that it was, in my view, the best evaluation of all these models worldwide and obviously internationally. It was quite detailed. And it did show some really interesting aspects. The first part is that the vast majority of the work that was coming to the Wellington team was coming through the police 111 system, which was expected, and only a minority of work was coming from either the ambulance services or other sources. So the work that the co-response team was dealing with was coming through a 111 police system. Most of the people that they saw over that 1 year period were previous clients of mental health services, and I believe that was in the last 5 years. So it does show that we're not dealing with people who aren't known to services. We are dealing with people, service users, if I call them that, who are known quite widely across services often. What we also found was that a lot of the people that we took to ED had been to EDs previously in the last 12 months. And the co-response team in that 1 year period was attending to just over 60% of the people in their homes, which is a fantastic outcome. We move to the next slide there. Stephen, would be great. So some of the benefits that they saw from the CRT, this was the evaluation. One of the key things is the strengthened relationships between the agencies. And it is referenced in the report that there is actually a level of distrust between police and mental health services in particular. Operationally, that is often driven from historical issues of police wanting or expecting things from mental health services, and they go, hey, they're not providing it, and mental health services expecting certain things from the police, and they think they're not providing it. And over the years, that kind of whittles away trust between the agencies. And the CRT was a very good, and evaluated here as a model that restored trust, which from a service level delivery, certainly from our space, is critical to making sure that things move forward and progress properly. Some of the other evaluated benefits was that the co-response team response was far better than just the standard police response. The users, the service users that they attended to rated the service quite highly, and certainly from my perspective, the whānau of the service users who were interviewed rated the service extremely highly, and it came through quite clearly in the evaluation about a deep frustration from family members of service users and their engagements with the systems and the dynamics that they had to go through. And when the co-response team attended to them in person and spoke to the families, that was rated extremely highly as a very empathetic listening service on scene, which is obviously what a lot of people felt was lacking. Certainly from a police perspective, they believed that service was providing a significant assistance in a space that we had no assistance before. We were often left just sort of wandering around in the darkness at a lot of the work that we were going to, and then having someone that a police officer on the scene could speak to, or the co-response team could then go out and assist them at the work, was deemed to be pretty invaluable. Certainly mental health services found them beneficial as well, primarily I believe on the accessibility of the co-response team. As time progressed, they started leaning on the co-response team more. The mental health crisis services speaking to them, asking questions, what should we do about this, what should we do about that, and that was rated as quite beneficial as well. Next slide, thanks Stephen. So just some last thoughts very quickly on what I think CRTs should be doing. Very clear, keep in mind that they're working in an emergency space. They have to focus on two work streams. One is response, responding to the right jobs quickly and getting on scene. That's the evaluation shows that actually provides really good outcomes, but also on coordination and liaison work, which is when the work is flowing through the 111 system, intervening in that as soon as possible, where possible, to divert it out of the police system. One of the difficulties we have is determining what is for police and what isn't, and a co-response team can do a good job about helping us determine what we should send a patrol car to and what we shouldn't to. And if you can get that early direction, that provides big outcomes, benefits for everyone involved. We know they need to be accessible to other agencies. That's really important. They need to be able to link in quite quickly with appropriate services, including cultural services. And that links back to them being accessible. The co-response teams need to be known in their district. They need to be known in their region. They need to be known in their area. They need to be contactable. And the bottom line is they are specialist teams. They are small teams, often made up. We have about another 5 around the country now on top of the Wellington one, often not involving more than 4 or 5, 6 members. Specialist teams, kind of individual-based teams. Individual motivation is really important. And to get the co-response team working properly, I would call it, you need a high-performing culture. They need to be active, proactive, getting out there and working quite hard, because that's what all specialist teams are like. As I said, I'm here to answer some questions. So thank you for that, and look forward to seeing what you have to ask me. Back to you, I think it is Sonya or Barbara, I can't recall.
It's back to me. And look, thank you very much to the 3 of you, Sonya, Ruth and Matt, for setting up the context and giving us an inroad into some future questions and discussions. So really, really helpful. So just, I've got a question, and Matt, given you've just finished, this first question's going to be for you. Just remember, please put your questions into the little question box, which is down there, the Q&A box, and they'll come through to me, and I can then make sure they get asked. So, Matt, following on from your discussion, what's the clear boundary between police response and mental health in crisis work? So what does the literature say about what's best between the emergency response and the health response? So, Matt, are you happy to answer that or give it a go?
Yeah. Look, I think the difficulty which most people know that police are trying to figure out at the moment is where police should and shouldn't be involved in mental health work. And what we have been determining, certainly over the last couple of years, is we know that when police officers are arriving on scene to work that doesn't need police powers or capabilities or those particular skill sets, there is a high likelihood, or a pretty decent likelihood, of inadvertently causing trauma. So that's the first point I always point out here, because the boundaries between what is crisis work and what is police work, you can't just say there's an overlap, because there is always going to be an overlap, but it's really about defining about exactly where do we want police to be. So if you understand about where police should be, which is where police powers, capabilities should be used, you start to realize that there's that actually most times sits in quite the high end of mental health work, the really high critical emergency interventions. Because once you move out of that zone, it becomes more what I might describe as urgent work. It's not emergency, it's urgent work. And once it moves into the urgent space, it becomes what I would call more crisis resolution services. And now I think most people would understand that. But the boundary between those two things can be a little bit blurred at times. But we kind of define it as, well, if you need police to save a life, to get to the job quickly, to do that, to make people safe, to prevent significant harm, where we use our powers and capabilities, then that's at the police space. But then once you move out of that, it moves into what I've deemed to be a more crisis space. Hopefully that, I don't know if that exactly answered the question, but that's the way I view that.
Great. Thank you, Matt. That was really, really helpful. So Ruth, over to you, and lots of positive comments coming through about Piri Pono. So that's absolutely fabulous. The next response, oops, don't know why my video's gone off, but it won't come back on. Oh, there it is. Sorry about that. So question for you, Ruth. How can peer support roles support crisis responses, including in the context of self-harm or risk? Quite a tricky question. So
Yep, no, it is. Obviously, I think we'll start from the basis that all peer support workers are trained. This is actually a professional workforce, and so it's. I think that's an important point. We are moving towards a terminology of referring to peer support specialists, and the focus for example, using Piri Pono as an example, someone coming in acute distress, the relationship building, the sitting down, the sharing of kai, the not being in a challenging environment, not being heightened distress by being in the hospital environment is helpful, and we have evidence. I haven't brought it today, but if anyone wants, we've got an evaluation again, which was done a long time ago now. The service has been going a long time, which showed that way of peer-to-peer, of experiential discussion, of the training in trauma-informed responses that the peer support workers and peer support specialists have, leads to a more rapid de-escalation, if I can use that word, for people feeling calmer. The service, as I said, does have nurses on site too, although they're lived experience. So they're registered nurses, so they work within the standard mental health nursing scope of practice and support peer support workers. And the one thing that is also important is that the ratios of peers to guests is quite high. We've just actually had our beds increased to 6 from 5, but we will have 4 peers, including a nurse, so 3 peers and a nurse on shift all of the time, reducing to 1-on-1 overnight. So there is time to spend with people, and that is I think, one of the most valuable things that model has for people. It's that caring. Nothing feels rushed, nothing feels difficult and challenging, and so having someone to just sit alongside you is one of the best ways to reduce the immediacy of self-harm.
Right. And Ruth, just sort of thinking about that in relation to perhaps other contexts for a crisis support, do you have any views about how the use of peer support roles can work, and knowledge of some of the other crisis support mechanisms, like say crisis cafes?
Yeah, we as Ember, so I'm speaking on behalf of Ember at the moment, but we are now delivering the crisis cafe, though we're calling it a peer support hub, to make it feel more accessible in counties Manukau. And again, we are using a mixture of peer support specialists and peer clinicians to run that space. So the same principle applies, and also making sure that it's active support as well. We're also doing 3 of the peer in ED pilots at the moment, again with our peers working alongside those that are going to the emergency departments, possibly not then. I mean, to be fair, we'd had quite a lot of data already, particularly from our Auckland pilot, where the peers are working with people that are going to ED in emotional distress, in mental health crisis, but a lot of their work is also with people who have never used mental health services, but actually benefit from understanding what support networks there are, and certainly whānau in that space as well. I think it's an interesting space in the crisis cafe nationally, in those models, and peers in ED, to just ensure that there's not a step over or a shadowing into. People do need to use other emergency services. People do go to ED who have mental health or addiction issues, who need a physical medical response, and making sure that we can also advocate for that, because that diagnostic overshadowing can actually be a challenge in those environments, and we're trying to work hard through the peer response to help support that to be better.
Good.
Does that answer the question?
Thank you for that. That's been really helpful. Okay, Sonya, you're not resting anymore. One for you. This person's interested to know if the literature search revealed what is helpful and valued for friends and whānau supporting someone in acute mental health distress. So that's just a little one for you.
Yeah, look, that's a really good question. So it didn't go into that in detail, but what it did do is talk about what makes a good crisis response system, and so involvement of family in that is a critical kind of success factor. So a number of the models, both overseas and here in Aotearoa, talked about the importance of that whānau involvement, and actually that they're part of that support network, but also walking alongside people who are accessing those services. So it didn't look specifically at the experiences for those whānau members, but I think it's a really important point and something that we need to be thinking about for future work. So thank you.
Right. There was a question I noticed flick up as well as we were going through. It came through the chat, looking at young people and whether Ruth, young people are able to access the services, or what services might be available for young people under 18. So I'm just going to throw that over. Perhaps Sonya, the literature search might have found something up there, and Ruth or Matt, you might know what's happening on the ground.
Yeah, well, I'll start and then maybe I'll hand to you, Ruth. So in terms of what the literature scan found, it found a couple of really good examples of services that are being delivered for young people in crisis. And the key feature of those services was community-based and home-based. So actually moving away. So a number of countries in their models talk about moving away from hospital-based services and recognising the disruption that causes when people are admitted into hospital-based services. So really looking at a range of alternative models that can support people but ensure they can continue to attend school, for example, and be involved with their family. So I think that's a really positive move that we're seeing overseas.
Great.
I'll hand to
and
you,
Matt or Ruth,
yeah.
do you have anything to add there?
I have nothing specific to add, and I'm probably certainly not the expert in this field. Ember works in the adult space, and so, but one of the things I just wanted to touch base a little bit on Sonya's response earlier to the family. One of the things that comes through very clearly for all of our peer-led services, and actually wider that to NGO services, is that whānau feel less challenged by the environments when they are warm and inviting, and hospital itself is not just challenging and adds to distress for the tangata whaiora, it does for whānau as well. So I just wanted to add that point.
Great, thanks Ruth. Matt, anything for you? Or
no? Oh, that's very quick. Look, in regards to police, the response to youth in this space, the mental health space, well, is it an emergency or not? If it's an emergency, it doesn't matter whether they're youth, adult, whoever. That's what we go to, right? In the whānau space, going back to that previous questions, I think one of the things that has been highlighted through the advent of the CRTs is, firstly, we also know that the majority of people calling in the 111 space are actually whānau, family whānau and friends. I think it's about 70% of our work comes from people calling about another person. So it's very important, whatever service it is that they get back in touch with people and tell them what's going on. And that is something that we've been seeing lacking over the years. When somewhere we attend, we take people away to tell us some service or whatever happens. And then there's the lack of follow-up back to the family and whānau from mental health services. And I'm not getting into the dynamics, but that has been something that's highlighted over the years to me.
Great, thanks Matt. Sonya, another question for you. What is the potential for advanced directives for crisis services? How does this influence a good crisis response, such as person-centred care?
Right, wow, yeah, so there's a lot of work happening around advanced directives at the moment, and so in terms of, I guess, there's huge opportunity there, I think, for people to determine what they want in terms of crisis response and being really clear about that. One of the things that we're very aware of is just making sure that when people have advanced directives in place, that first of all, they're available to the people who need to access them and can actually refer to them, and that they're followed. And I think there's a lot more work that we need to do to really understand. So I would say absolutely there's definitely a place for advanced directives, but we as a system need to make sure that the people who are responding can actually access those and follow them when they're needed. And I think there is some issues there in terms of that information flow, so people knowing that they know that someone has an advanced directive in place and should be seeking to find it and follow it.
Great.
As much as
and thank you, Sonya. And one more for you, Ruth. What does a good follow-up service after crisis response look like, and what do we have currently?
They look like something that Matt mentioned earlier, actually responsive, following up, involving whānau and community. It's certainly our experience that through Piri Pono and others, Tupuaki, which is a pathway service and so on, is that we have related outreach services. So there are services to refer people to, that you maintain a relationship. We will always talk to if the person has a clinician already, making sure that they're aware of other services, that there's not a gap. And we spend a lot of time with people trying to help them identify what their gaps are. What might have led them to need a crisis response, and what is it that we or others could do to reduce that need next time for it to be a crisis level response? How do we help them to find something slightly earlier? And there are lots of obvious different ways of doing that, but certainly linking, and it's really important that every crisis response has links to what the community and other providers can do in order to make sure that, because it takes a village, right? It takes a village to support someone. So just making sure that that village is known to everybody. Yeah.
Great. Okay, and we're probably getting near to the final questions, but this is for Sonya and Matt. So you can answer it in whatever order the two of you want. What lessons have you seen through the literature review and your experience about collaborative models, and what help makes them work really well? So maybe you can talk about the literature, Sonya, and you can talk, Matt, about your experience about what makes this work really well on the ground.
Yeah, sure. So I guess what the literature definitely very strongly shows is the importance of collaboration and that holistic approach. So recognising that's not just a health response. So I guess in terms of that, what came through the literature, absolutely, that all of the models that are kind of talked about, a lot of the examples, they're all collaborative models. They're not just single service. And so I think that's really important, because it just really highlights how important that collaboration is. And as we know, in New Zealand, we're moving to a much stronger health-led response to crisis. But I think it's really important to acknowledge that it's not only the health system, it's actually a collaboration of a number of different agencies that need to work together to really make that work for people. So so the literature was quite strong on that, both here and overseas. Matt, did you want to comment?
I guess what I've really noticed in this space, and I've been to the UK as well and seen a number of the things they do over there, is whatever you come up with in a collaborative space, it needs to be embedded into the larger part of the organisation. As I referenced earlier, and I talked about the co-response teams being specialist teams, one of the risks you have when you set up these new models is they sit outside of the main, and I'm talking about by the way, any new service. If it's a small service, it often sits outside the mainstream. And when you're trying to innovate and bring these new collaborative changes in, you need to bring them as much as you can into the main part of those agencies to influence and change everything around them. Because there's always a risk here about them sitting on the outside. And when they sit on the outside, they are intangible, they're kind of off there, they're doing their thing over there, but it doesn't impact us. You've got to bring them in. And when I say that, you need to bring them in, then you need to make those teams answerable to those agencies. They need to understand very clear goals and objectives. And they need to be incorporated into the whole. That's, generally speaking, I know there's lots of issues here about how do you do a good collaborative model, but what I've noticed over the years is these really good collaborative models, and whether they be crisis cafes or whatever police do, is they often kind of sit off to the side. And I think that's where we go wrong. We need to bring them in, far more answerable to the main agencies. And then, on my personal opinion, by doing that, we can then drive better change forward.
Great. Thanks. Now, just on to, thanks, Matt. On to the last couple of questions. We've only got a few minutes, so they'll need to be short. What would be needed in rural areas to support good crisis mental responses in areas where resources and services are much more minimal? That's for you, Sonya, just a little curly one.
For me, yeah, look, that is a great question, and something I think we struggle as a country to really understand. I guess what we would advocate for is that everybody in across Aotearoa has access to the services they need. We understand that that's more challenging in rural environments. So I think it's really thinking about, you know, how do we get the resources where they need to be, and how do we have examples of Piri Pono, Tupuaki and Te Marama available right across the country. And the Trieste model that I talked about earlier, that's a very locally based model, and I guess there are opportunities, I believe there are opportunities to have smaller local services that can cater better for rural communities.
Great. Last question, and this is just a little final one for all of you. There have been lots of questions about the potential of peer support in crisis response models and what needs to happen to realise this potential. Any comments about that from you? What needs to happen to really realise the potential that peers bring more fully?
I'll step into that one first, if I may. I think, and I'm not going to get political, but I do think that there needs to be an understanding at political levels of the importance and the value of peer support, and that there needs to be investment in evaluation. One of the things that's reasonably challenging at the moment is that we have a lot of initiatives, and I'm very grateful and thankful for them. The peer workforce is finally growing in a way it hasn't done for perhaps the last decade. But the services are being set up as pilots. They're being set up without evaluation at the front and foremost of those, which means that it's not being set up, I don't think, adequately to become totally systemic and totally embedded and to shift the balance. I also think that over time, that the peer and lived experience workforce is a place where we can utilize it fully and reduce reliance on the clinical workforce and allow clinicians to step up and work in their scope more fully and clearly, because we know that there are workforce challenges in that space. So I just think it's political will and commitment.
Great. And also you have clinical in your service, people in clinical roles who have lived experience, and building that capability seems an important thing. Okay.
Absolutely. So I'd say to that, Barbara, the challenges were, when we started 13 years ago, it was apparent that clinicians were in some places unwilling to share their lived experience openly. That's changing now, I believe, but it still needs to be more.
Yeah, great. Okay, any comments just finally from the other two? Matt, Sonya?
Oh, sorry.
I was just going to quickly say, a lot of the stuff that comes to the police through the 111 system, we know for a fact they're actually just needing someone to talk to. And I always say, in regards to some of this work, we shouldn't overcomplicate it. It's sometimes not as complicated as people think to get the right help. It's just they need someone to talk to often.
Great. Yep, connection's the key, somebody said in a comment. Sonya?
Oh, look, I was just going to quickly just say that Te Hiringa Mahara has advocated strongly for the growth of the peer support workforce, and we will continue to do that. We think it's a critical workforce, but just picking up on some of those points that Ruth made, it is important that we support that workforce to grow, develop not only in the frontline positions, but through the layers of leadership as well.
Right.
So, yeah, just
Right.
wanted to shout out.
Look, thank you, everybody. Especially thank you to our three speakers here who've put themselves on the line. Thank you, Sonya. Thank you, Ruth. Thank you, Matt. Now, just before we go, I want to remind you that there is a conference coming up pretty quickly. It's on the 5th of November, and it is going to be looking at crisis response. People are invited to register for that. And just we've flicked it up on the screen here so that you can see where it is. It'll be in Auckland, Tamaki Makaurau at the Waipuno Lodge. So registrations are open, so please please look at that if you're really interested in this and want to do more. And thank you to everybody. I will just hand over to Sonya. We're at a minute over for her to close. Thank you for your participation. It's been great to have the opportunity to engage with you all. Thank you.
Yeah, kia ora, Barbara. And yeah, just thanks everyone for making the time. Really appreciate it. I'll close us with karakia. Onehia, onehia. Onehia te uru tapu nui. Kia wātia, kia mama, te nākau, te tinana, te wairua i te ara takatu. Koia rā e rongo, whakeria ake ki runga. Kia wātia, au rā, ko wātia, hau pai, mārere. Thanks everyone.
Ka kite.
Ka kite.